I'm Anandita Kulkarni. I'm a preventive cardiologist and women's heart specialist. I head the Center for Cardiovascular Disease Prevention at the Heart Hospital Baylor Plano, which focuses on preventing heart disease and has a special focus on women's cardiovascular health. Today, it is my distinct pleasure to be joined by Dr. Subhash Banerjee and Catherine McNeil, both of whom are nationally renowned experts in heart disease in women. Dr. Banerjee is an interventional cardiologist who serves as the Paul J. Thomas Endowed Chair in Cardiology and Chief of Cardiovascular Research and Innovation for Baylor Scott & White Heart and Vascular Services in Dallas. Dr. McNeil is a cardiologist who specializes in women's cardiovascular health and complex lipid disorders. Over the course of today's webinar, you will have the opportunity to hear each of us speak about various aspects of women's cardiovascular health. At the end of our webinar, there will be a brief question and answer session, and you will have the opportunity to submit your questions via the chat box. A simple Google search of the word heart disease populates a number of images, the majority of which depict men. Looking at these images, one would think that the overwhelming majority of heart disease occurs in men. However, in reality, heart disease is the #1 killer in men and women alike. Heart disease is less likely to be recognized in women when compared to men, and women are less likely to be treated for their risk factors for heart disease. Another Google search will show you what we prioritize when we think about women's health. These images depict a sample of images that are pulled up when I search for women's health. Pregnancy and gynecologic issues, although abundant, we're really talking about heart disease in women in the popular media. And that's a problem. It's really important to note that heart disease affects men and women nearly equally. And we need to raise awareness about this important issue so that our mothers, sisters, and friends are treated appropriately. I'd like to bring your attention to this graph that shows us the trends of deaths from heart disease over the last several decades. One of the most important turning points that contributed to fewer women dying of heart disease was the implementation of awareness campaigns for women and heart disease, much of which has been led by the American Heart Association. In addition, the American Heart Association outlines 8 metrics that we call Life's Essential 8 that are important aspects of achieving health. These include eating a heart-healthy diet, being active, quitting or not starting smoking, getting a healthy amount of sleep, managing weight, controlling cholesterol, managing blood sugar, and managing blood pressure. In our series of talks today, you will learn more about the Essential 8, as well as important steps that you can take to prevent or reduce your risk of heart disease. First off, we're going to hear from Dr. Banerjee.
My name is Dr. Subhash Banerjee. I'm an interventional cardiologist at Baylor Scott & White Heart and Vascular Hospital. I'm delighted to speak to you all about cardiovascular disease in women, redefining women's health. I'll start off by talking about cardiovascular disease prevalence in women, some concepts about pathophysiology, but the main thrust is going to be about case examples of women with heart disease. Cardiovascular disease remains the most common cause of death among US women and men. During the past nearly 2 decades, basic discoveries and clinical research have uncovered important biological differences between women and men, and differences in their respective responses to social, environmental, and behavioral stresses as well. Traditional cardiovascular risk factors such as hypertension, hyperlipidemia, obesity, smoking, sedentary lifestyle, and diabetes are highly prevalent among US women as they are in men, with notable racial and ethnic differences. Hypertension is highest in non-Hispanic Black women. Low-density lipoprotein cholesterol is highest in non-Hispanic white women. Diabetes is highest among Hispanic, and overweight and obesity is highest among non-Hispanic Black and Hispanic women. Nearly half, about 44% of US women above the age of 20 years of age have some form of cardiovascular disease, including hypertension. As shown in the figure, disparities by race and ethnicity are substantial. And the prevalence of coronary heart disease, heart failure, and stroke are all highest in non-Hispanic Black women. Let me speak about some pathophysiological features of heart disease in women. Women's risk exceeds men after menopause, highlighting the cardioprotective influence of sex hormones, particularly estrogens. There are various female-specific diseases associated with dysregulation of sex hormones like polycystic ovarian disease, premature menopause, that increase cardiovascular risk. I'm also going to talk about different phenotypes or specific phenotypes of cardiovascular disease in women, like macrovascular disease, microvascular disease, ischemic heart disease without obstructive coronary arteries, heart failure with preserved ejection fraction, Takotsubo's cardiomyopathy, and postpartum cardiomyopathy. A few important facts about coronary artery disease in women. There is a higher impact of traditional cardiovascular risk factors. The overall risk burden in women is less than in men. However, their presentations can be non-typical, which then accounts for some worse prognosis despite lower atherosclerotic plaque burden. We see more plaque erosions in patients with acute coronary syndrome with less necrotic core and calcification. Entities like MINOCA, myocardial infarction with non-obstructive coronary disease, and spontaneous coronary artery dissection are going to be topics in the case presentation. A lot of diagnostic testing that we're going to talk about are going to be relevant. And before I jump into those, let me talk about some important specificities of imaging in women. During cardiac CT, we notice higher heart rates in women, less calcific plaque, smaller diameter of arteries, and higher fractional flow reserve during CT assessment for a given stenosis. For cardiac MR, women have smaller left ventricular cavities, especially postmenopausal. There is left lateral tilt at a position of the heart in pregnant women, and there are higher T1 and extracellular volume mapping values that are noticed in women, and women have greater claustrophobia. For myocardial perfusion imaging with SPECT, smaller left ventricular size, breast attenuation artifact, and higher vasodilation side effects are all things that we see in women. For PET imaging, we record consistently higher myocardial blood flow at rest and lower coronary flow reserve values in women. For angiography that I do routinely, we definitely see smaller caliber radial arteries, greater propensity for spasm, smaller coronary artery dimensions, and higher dissection risk in women. I would like to spend a few minutes on cancer-related cardiac dysfunction in women, with more women surviving cancer. CTRCD, the abbreviation, accounts for a drop in left ventricular ejection fraction to below 50% or a 10% or more drop from baseline. We also look at reduction in global longitudinal strain values greater than 15% from baseline, and for which cardiac MR is far more accurate than a routine transthoracic echocardiogram. Extracellular volume and T1 mapping help detect myocardial fibrosis and also subclinical cardiotoxicity and coronary artery disease with the various combinations of drugs that are used to treat cancer therapies in women, especially anthracycline and trastuzumab. Various agents shown on the slide also increase the risk for arterial thrombosis, vasospasm, and coronary plaque rupture. This is a story about a 30-year-old female 6 weeks after her uncomplicated C-section that presented with complaints of 2 weeks of intermittent chest pain. Her troponin levels were mildly elevated and ECG showed no abnormality suggestive of myocardial ischemia. She underwent a triple rule-out with a coronary CT scan that showed no evidence of calcification or stenosis, but revealed a complete occlusion of the distal segment of the left anterior descending artery. She then underwent invasive coronary angiography that confirmed the diagnosis of spontaneous coronary artery dissection without signs of regional or diffuse hypokinesis on ventriculography. She was treated conservatively with dual antiplatelet therapy, and 6 weeks later, a repeat invasive coronary angiogram confirmed spontaneous and partial revascularization. A SPECT PET myocardial perfusion test was done that showed no signs of scar or ischemia. This case is about a 31-year-old woman with history of polycystic ovarian disease, obesity, and no family history of cardiovascular disease, who was referred to the hospital for a planned C-section. Her pregnancy has been complicated by hypertension and diabetes. The aftermath of delivery was marked by episodes of non-sustained ventricular tachycardia and dyspnea. Troponin and BNP values were within normal range, and echocardiography showed reduced LV systolic function between 35 and 40%, which was then confirmed with cardiac MR. We did confirm the 42% ejection fraction with no regional component. No myocardial late gadolinium enhancement was detected that excluded necrosis, and pharmacological stress revealed no ischemia. T1 and T2 mapping of the left ventricular myocardium were normal, thus excluding scar and edema and myocarditis. So the key to the diagnosis of this patient was postpartum cardiomyopathy, is the timing of the disease and the absence of cardiomyopathies with advanced imaging. This is a 60-year-old woman with severe hypercholesterolemia who presented to the cardiology outpatient clinic for routine evaluation. A snapshot of the ECG shown here confirmed loss of R wave progression and biphasic T waves in anterior precordium and lateral leads, respectively. Echocardiography revealed isolated apical akinesis with preserved overall LV ejection fraction. Subsequent invasive coronary angiography was normal. The patient went on to get a technetium myocardial perfusion SPECT imaging, which confirmed reduced end systolic thickening and anterior apical hypokinesis. Overall, the LV stress perfusion at rest were normal. The investigators of this case and the physicians went ahead to do an ECG-gated MIBG SPECT and a FDG PET-CT that showed concordant alterations of adrenergic innervation, that is the panel in E, and abnormal glucose metabolism in the apical and anterior LV walls. This is a case of silent Takotsubo that was triggered by emotional stress at work, and I think this highlights that Takotsubo cardiomyopathy can often be caused by severe emotional stress. This is a 71-year-old woman with history of obesity, diabetes, type 2, who was referred to the clinic for worsening dyspnea. Clinically, no other signs of congestion or fluid retention were observed, and the ECG showed atrial fibrillation, and NT-proBNP values were significantly elevated. Echocardiography displayed a preserved overall LV systolic function, severe concentric hypertrophy, and evidence of type 2 diastolic dysfunction. The images on the slide show the cardiac MR findings that confirmed the preserved LV ejection fraction, non-dilated but hypertrophied LV, and in addition, late gadolinium enhancement imaging showed no scar and a dilated left atrium was detected. These patients can be challenging to manage, and apart from ACE inhibitors and diuretics, the neprilysin inhibitor and empagliflozin have been shown to recently reduce cardiovascular mortality and the rate of rehospitalization with patients with heart failure and preserved ejection fraction. I would highlight that comorbid conditions such as hypertension, diabetes, and obesity play a central role in the development of heart failure with preserved EF, particularly in women. A 62-year-old female with hypertension and history of polycystic ovarian disease presents with non-typical anginal symptoms. Stress ECG reproduced symptoms with anterior T-wave inversions as shown on the slide. Coronary calcium score was 5 with minimal calcification in the proximal left anterior descending artery. Images of the PET myocardial perfusion imaging revealed normal myocardial perfusion and no defects suggestive of ischemia or scar. However, the coronary flow reserve was less than 2 in all myocardial segments. The patient was treated with long-acting nitrates and beta blockers and relieved of her symptoms. And this highlights a case of coronary microvascular disease. And 2/3 of women with chest pain and non-obstructive coronary artery disease present in a similar fashion with abnormal coronary flow reserve. And this diagnosis is consistent with coronary microvascular disease. Our next patient is a 28-year-old woman with no medical history other than smoking, and she was admitted to the intensive care unit after an out-of-hospital cardiac arrest with ventricular fibrillation and return of spontaneous circulation after 8 minutes of CPR and external defibrillation. On admission, her ECG revealed ST segment elevation in anterior leads. Echocardiography showed a hypokinetic anterior left ventricular wall. An invasive coronary angiography to rule out myocardial infarction showed normal coronary arteries and a hypokinetic apex with EF of 40%. This was confirmed later in about 10 days with cardiac MR that displayed normalization of the LV and wall motion abnormalities and no signs of myocardial scar or edema. A second invasive coronary angiography was then performed for assessment of her coronary microvascular function and coronary vasoreactivity testing. The coronary flow reserve was 4.5, and following intracoronary infusion of 100 micrograms of acetylcholine, all three criteria for vasospastic angina were met. The patient had coronary vasospasm, as shown on the slide, angina, and ST segment elevation. Upon discharge, a defibrillator was implanted and long-term treatment with calcium channel blockers and long-acting nitrates were recommended. The patient overall did well and still is continuing to remain in follow-up as per the reported case. Hopefully, these case examples cement a pathway of evaluation for women with cardiovascular symptoms and presentation. I don't intend to go over these flowcharts in extreme detail, but simply to emphasize that both for patients with acute coronary syndrome and chronic stable angina, their risk that predisposes them to cardiovascular diseases should be assessed carefully, and appropriate tests that range from coronary CT to invasive angiography, cardiac MR, and advanced nuclear imaging should be undertaken. Let me close by highlighting a case that is still fresh in my memory from the last month at the Baylor Heart and Vascular Hospital in Dallas about a 52-year-old woman who presented with crushing chest pain to the emergency room that escalated over 30 minutes during her drive home from work. She has been having workplace conflicts leading to closure of her real estate company. You see here an electrocardiogram shown on this slide, which doesn't reveal any acute changes. However, her troponins were moderately elevated, and she was then referred for coronary angiography. The two images of the left and right coronary angiography are shown, and it revealed normal coronary arteries without any epicardial stenosis. Given her overall LVEF on ventriculography that was about 40 to 45%, we proceeded with cardiac MR imaging. That is the last video on the right side that shows classic evidence of a mid-ventricular Takotsubo cardiomyopathy. It's been a real pleasure to share this information about women and heart disease with you all. Of course, the objective is to optimize both clinical care and prevention strategies and raise awareness in our communities and advocate for continuing research in this area. Thank you very much for this opportunity.
I'm Dr. McNeil. I'm going to be talking to you about lipids today, specifically cholesterol and triglycerides. And I would say that this is going to be a little bit like a Duolingo lesson on lipids. So hopefully by the time we finish my section here today, you will be able to speak like a lipidologist. As Dr. Banerjee has described so much of today, coronary heart disease is caused by the buildup of cholesterol, which we call plaques, in the heart arteries. So in the arteries and not the veins. Remember, veins are blue, you can't feel them pulsating, whereas your arteries are something you can't see but can feel them pulsating. And the arteries carry blood that has oxygen in it that nourish the heart muscle. So if there is plaque formation in the arteries, the blood has to slow down in these arteries. The lack of blood flow causes decreased oxygen supply to the heart muscle. That's also called ischemia. Ischemia causes pain, angina or angina, and prolonged ischemia causes the heart muscle to die, and that's equivalent to a myocardial infarction or heart attack, as we call it. So you'll hear the terms ASCVD, atherosclerotic cardiovascular disease, and CVD, cardiovascular disease. And those all refer to this very broad disease that includes not only heart disease, but also strokes, mini strokes, and peripheral arterial disease, the blockage of the arteries in the legs. So the good news about atherosclerotic cardiovascular disease is that the plaque develops very, very slowly in the arteries, over a decade or more. And I see children and adults with high cholesterol. And one of the compelling reasons we use to treat children for very high cholesterol is to prevent this very slow buildup of plaque from actually ever happening in the arteries. So risk factors for cardiovascular disease, which I'll list for you in just a minute, are usually additive, are usually not additive, and they multiply each other's side effects. So if you have genetically high cholesterol, for example, that in itself can be certainly a risk factor, but not as bad as if you amplify it by also smoking or having diabetes. So what exactly is cholesterol? Why do we worry about it, and why do we talk about it all the time? Cholesterol is one of the two fats in the blood, and we need it. It's essential for good health, forming the walls of the arteries, forming nerve cells, sex hormones, vitamins, a myriad of things in our body. So because cholesterol is so important, every cell in our body actually makes cholesterol. Now, we all know that to lower cholesterol, we should decrease saturated and unsaturated fats in our diet. And a good diet, I saw that in the chat line, somebody asked about, what's the best diet for heart healthy eating? And it's usually the first one we're going to mention is always going to be probably the Mediterranean diet. Now, I'm sorry I didn't put it on the slide here, but I want to emphasize that a majority of the cholesterol actually is made by the body because it's so important. But in some people, they make too much cholesterol, or more realistically, that cholesterol, which is made by the liver, is not taken back up out of the liver. And so in some people, not only do we need to follow a low cholesterol diet, but we use medications, typically statins. And what the statins do is simply help the liver take up the cholesterol more efficiently, like it's supposed to. Fat does not mix with water, which is the main component of our blood. So cholesterol is carried in the blood by lipoproteins. Now, I'm just going to switch over here because I want to mention the second fat is triglyceride. And people often confuse that cholesterol with triglycerides, saying, oh, my cholesterol is high, when they actually mean they have hyperlipidemia, high lipids, and it is the triglyceride that's high. Triglycerides are important because other than glucose or blood sugar, it is one of the fuels we need to run our bodies, to help us breathe, move muscles, all of those activities that occur during the day. And in the case of triglycerides, remember I mentioned that you can increase your cholesterol by eating a lot of by eating a lot of bad fat, but the triglycerides come from sugars and starches. And so usually we can lower triglycerides in the diet by going on a low carbohydrate diet, but triglycerides don't cause the buildup of fat in the arteries. Here is that gradual buildup of plaque that Dr. Banerjee talked about. And what causes a heart attack is actually not this very gradual buildup of fat, but this blood clot that forms over where plaque is ruptured. And so when the blood is coursing through the heart artery, it encounters that blood clot, and voila, no more oxygen supply to the heart muscle, and that's where we get the heart attack and the ischemia. So an easy way to think about the good and bad cholesterol is that here's say a construction worker, and he's pouring down this lousy cholesterol that's causing this buildup of plaque in the artery. And here's another guy that's trying to vacuum it up or carry it off as fast as he can. So that's why you want your heavenly or good cholesterol to be high. It's like a vacuum cleaner, and you want the lousy or bad cholesterol to be low. There's actually a number of different types of lipoproteins in the blood, and we're not going to talk about these other two, the remnants and the lipoprotein A today, except I do want to say that in addition to screening for high cholesterol, many guidelines now recommend screening for this special type of the lipoprotein A. I keep using the term lipoprotein, and it's really a simple translation. It's just a fat-carrying protein. And, you know, these acronyms, LDL and HDL, what do they stand for? It's actually how dense or heavy these lipoproteins are, how quickly they would fall to the bottom of a test tube. So there's low density lipoprotein, high density lipoprotein, and in actuality, there is a continuum in size of these lipoproteins. And all of these lipoprotein particles carry cholesterol and carry triglycerides. So in the lab, we calculate the LDL cholesterol, the cholesterol carried by the LDL particle, and the cholesterol carried by the HDL particle. So here is my bucket lecture. So instead of thinking about lipoprotein particles, we're going to think about them as buckets that come in different sizes, right? And so instead of small, medium, and large, we're going to talk about how dense or heavy they are. So there's all the way from low density, very low density, high density lipoproteins, and then this fourth type of bucket, the lipoprotein A that I mentioned to you. And every single bucket has cholesterol and triglycerides in it, some to differing amounts. So when you get your lipid panel, it is the cholesterol carried by the LDL buckets that are in it. It's the cholesterol carried by the HDL buckets that are in it. And by the way, I want to mention when we get a lipoprotein A measurement, it's actually the number of buckets we're measuring, not the cholesterol carried by it. And the cholesterol carried by lipoprotein A buckets is indistinguishable from the cholesterol carried by the LDL buckets, so it's included all in one measurement. And so that's the calculated LDL cholesterol on your lipid panel. And then sometimes you will also see non-HDL cholesterol. And in plain English, if you take your total cholesterol level and subtract the amount of HDL cholesterol, you will end up with everything that's in all of these buckets. So let me go back here for a second and just I better not do that. Okay, but in that slide, I talked about remnants and lipoprotein A. So those included all of those non-HDL particles. It's important to know what the optimal level is for an individual person. And I'm going to distinguish between primary prevention and secondary prevention. So let me explain that. Primary prevention refers to people who have not had any cardiovascular diseases. So we're trying to prevent them. And in primary prevention, generally, the LDL cholesterol should be lower than 100 milligrams per deciliter, but the lower the better. And every cell in the body makes cholesterol. So low levels in the blood can still be very safe. And in fact, there are genetic conditions where people are born without cholesterol, and the only side effect they have is that they don't develop cardiovascular disease later in life. The heavenly or good cholesterol, your vacuum cleaner, right? We want that to be as high as possible because you want the vacuum cleaner full of dirt, so generally above 50 milligrams per deciliter. And for the triglycerides, it should be less than 150 milligrams per deciliter. But honestly, the lower the better, the higher the better for the HDL cholesterol, and the lower the better for the lousy cholesterol. One of the things that your physicians will do is to estimate your risk of developing cardiovascular diseases. And you can, if you'll Google cardiovascular disease risk calculator, you will actually be able to go in and put your numbers in and figure out what your risk of having a heart attack or stroke is. And it is that risk, very much like calculating how much life insurance would cost. It's that risk level that determines, do you need to just continue with diet, or should you perhaps take a cholesterol-lowering medication, a statin. I want to point out two things. Now, Dr. Kulkarni is going to talk about some of these risk enhancers that are specific to women, and I'm going to highlight a few of them in the next talk. But the other part is this, and I forgot to put a red circle around this category, because an LDL cholesterol generally above 190 milligrams per deciliter is considered to be genetically high cholesterol. And that's very different than high cholesterol induced by a diet. You have to have extremely high levels of fat in the diet to get an LDL cholesterol above 190. So that's usually a tipping point that we use to say, well, you probably have, genetically high cholesterol. And if you have genetically high cholesterol, it's actually been that high since you were about 2 or 3. So it's kind of like if a child were to start smoking from the age of 2 or 3, and now they're an adult. So there's been this lifetime exposure to high cholesterol that markedly increases risk. So let me go back to these risk-enhancing factors. A family history of premature atherosclerotic cardiovascular disease. And premature, we always have these lines, these cut points, right? So we say less than 55 for men and less than 65 for women. But in truth, it's around those ages. And this is a history of premature heart attacks, strokes, and diseases that affect the arteries, right? So family history of premature cardiovascular disease can account for risk factors that we don't typically measure. So something more than smoking, diabetes, high cholesterol, low good cholesterol. I've already talked about genetically high or primary hypercholesterolemia. Typically, we say if that's your only risk factor, about 50% of men by the age of 50 and about 30% of women by the age of 60 will develop cardiovascular disease. We don't talk about it much now, but metabolic syndrome is a constellation of risk factors. Some elevated triglycerides, slightly elevated blood sugar, glucose, not necessarily diabetes, but an elevated glucose, a low HDL, belly fat. Any of these three things make the metabolic syndrome, and that actually confers a high risk of future cardiovascular disease. If you've been diagnosed with chronic kidney disease, that is also a risk factor. You may see on your lab reports this very complex equation called the estimated glomerular filtration rate, GFR. That's how fast the kidneys filter out the waste products in the blood. Chronic inflammatory conditions like rheumatoid arthritis, lupus, HIV, even psoriasis. These chronic inflammatory conditions can accelerate the development of cardiovascular disease when other risk factors are present. Dr. Kulkarni is going to talk to you about these very specific risk factors associated with women. Some races and ethnicities, like South Asians, are more prone to develop cardiovascular disease. We've talked about some of the lipid-related issues. I talked about the elevated lipoprotein A, so you might, your physicians might be ordering that test for you. Another test that's commonly ordered is high sensitivity C-reactive protein. This is a marker of inflammation in the heart arteries, and inflammation in the heart arteries is evil, so low is good, but C-reactive protein is a protein that can be, is produced by the liver and can be elevated with any inflammatory condition, and especially infections or inflammatory diseases will increase it. I'm not going to talk about ApoB today. We don't typically measure that in the States. ABI stands for ankle brachial artery index, and that is simply a measure of how fast the blood flows in the leg arteries, so a measurement of peripheral arterial disease. So I'm going to close with this just to, again, summarize the difference between the good and the bad cholesterol. And just remember, the bad cholesterol has a very evil laugh. So I'll turn it over to Dr. Kulkarni now to talk again about some factors that are more specific than women, and really appreciate everyone's participation today. Look forward to some good questions at the end of this at the end of our presentations.
We just heard some great talks from my colleagues, Drs. Banerjee and McNeil, on heart disease in women and how the elements of life's essential 8, particularly cholesterol, play into this. In my section of today's talk, I'd like to take this a little bit deeper and talk about risk factors for heart disease that are truly unique to women and how we can try to uncover them. First and foremost, I'd like to bring to your attention this figure that I've put together that shows you a variety of risk factors that are specific to women that have been associated with an increased risk for heart disease. These are risk factors that span throughout a woman's life, ranging from pre-pregnancy conditions such as early menarche, the types of hormonal contraceptives that you use, polycystic ovarian syndrome, and spontaneous pregnancy loss, to complications during pregnancy that we call adverse pregnancy outcomes. These include things like preeclampsia, gestational hypertension, gestational diabetes, preterm birth, and small for gestational age infant, and also extend into conditions affecting menopause, things like premature ovarian failure or early onset menopause. There are also conditions that are specific to women that can occur throughout one's lifetime. These include things like breast cancer. I have a lot of young women who ask me why they need to worry about heart disease when they're young and healthy. To answer that question, I'm going to focus on risk factors during pregnancy, one's risk for heart disease. The technical term for these risk factors is adverse pregnancy outcomes. We view pregnancy as a stress test on the body. For anyone who's had a baby, you know well enough that it takes a lot of energy to grow another human being. Pregnancy is a natural stress test on the body that can provide a glimpse into the future and unmask potential underlying risk factors for heart disease. Adverse pregnancy outcomes include conditions such as preeclampsia, gestational hypertension, gestational diabetes, preterm delivery, delivery of a small for gestational age infant, and recurrent spontaneous miscarriage. It's important to note that approximately 30% of women experience adverse pregnancy outcomes, so it's not as uncommon as you think. I'm going to focus on the 3 most common adverse pregnancy outcomes that have the strongest association with heart disease: gestational hypertension, preeclampsia, and gestational diabetes. Let's start out by talking about gestational hypertension. Gestational hypertension is a form of high blood pressure that occurs during pregnancy. It affects approximately 6% of all pregnancies. High blood pressure, defined as a blood pressure over 140/90 millimeters of mercury after 20 weeks gestation, constitutes gestational hypertension. Women who have gestational hypertension are at a higher risk for chronic hypertension after their pregnancy, as well as a higher risk for heart disease. Your OBGYN will monitor your blood pressure throughout your pregnancy. It is important to note that women with gestational hypertension should be routinely screened for high blood pressure and should be treated if they develop it in order to lower the risk of heart disease. Preeclampsia is a form of high blood pressure during pregnancy that is also characterized by high blood pressure, a blood pressure over 140/90 millimeters of mercury after 20 weeks gestation, however, is a much more severe form and has a few additional features that include protein in the urine and swelling of the hands and feet. Preeclampsia has one of the strongest associations with future risk of heart disease, and women with preeclampsia are at a high risk for developing chronic hypertension after pregnancy. It is important to note that if you have a diagnosis of preeclampsia, you should be screened for high blood pressure and treated for it to help lower or even prevent your risk of heart disease. Gestational diabetes is a common form of diabetes that occurs during pregnancy. Women who have gestational are at a higher risk of developing diabetes in the future. Even women who do not develop diabetes in the future are at an elevated risk of having heart disease. It is important to note that if you have a diagnosis of gestational diabetes, you should be screened routinely for the development of type 2 diabetes and should be treated for this to help lower your risk of heart disease in the future. The most important takeaway message from our talks today is that it is important to be proactive about your heart health to reduce or even prevent heart disease. Knowing your numbers, your blood pressure, your cholesterol, what your blood sugars are important to your cardiovascular health. If you have risk factors, it's important to be aware of them and to get treated. If you have questions about your heart health and what your risk for heart disease is, talk to a preventive cardiologist or a women's heart specialist to learn more about what you can do to prevent heart disease. It's never too early or too late to prioritize your heart health, and it's important to remember that approximately 80% of heart disease is actually preventable. Before I take questions, my one ask of every single one of you that is watching this webinar today is that you take an important point that you learned today and share it with a loved one, a sister, a mother, a friend, whoever it is. Heart disease in women does not get the attention that it deserves, and I hope that you will help us in spreading the word in our community. With that, I'm going to open it up for questions. I've seen a few really great questions already coming through the chat box. I'm going to start out with one of the questions that really caught my eye, which was, what are the signs of a heart attack? I think this is a really great question because when we go through our medical school training, we are all taught that a heart attack feels like an elephant sitting on your chest, and it's chest pain, and that's how we're trained. But as we've learned more and more about heart disease, particularly in women, we've learned that a heart attack doesn't always feel like chest pain. It can feel like shortness of breath or fatigue. Um, the difficulty in diagnosis and the variety of symptoms often causes the diagnosis of heart disease to be missed in women. What I tell my patients is if you feel like something is wrong with your body, it's important to get evaluated and see if it is a heart attack. Do you have anything to add for this question? All right, we'll move on to the next question. There's a really great question about what is a heart-healthy diet in detail. It's hard to say, it's hard to describe this in detail right now, but I will give you my general overview. So a heart-healthy diet is one that is rich in fresh fruits, vegetables, and whole grains. I counsel my patients on really trying to limit fast foods, processed foods, highly. We try to eat as close to the earth as possible to really and really focus on fresh. A lot of these diets also need to be tailored based on your individual risk factors, so it's hard to prescribe one general diet to everybody, but those are my general guidelines. I see a question that says, are eggs good for you if you must watch your cholesterol, and how many and how often? That's a really great question. Every egg yolk has approximately 200 to 300 milligrams of cholesterol in it. The egg whites don't really contain cholesterol. If you have high cholesterol, and that's specifically LDL cholesterol, we do ask you to watch your intake, specifically of egg yolks. I tell my patients that if you're making an omelet or scrambled eggs, toss out a few of the yolks and focus on the egg whites, which are a great source of protein and won't raise your cholesterol. So I don't necessarily specify a number, but it's really sort of dependent on your cholesterol and really individualized. There's another question that states, what is the role of triglycerides in heart disease? I'm going to pass this one on to Dr. McNeil.
Okay, sure. Kind of complex. I wish I could go back to one of my slides, but you might remember that there was a slide that showed the heavenly cholesterol, the lousy cholesterol, and remnant cholesterol. And triglycerides themselves, we don't really find in that plaque buildup. We find the remnant cholesterol, which can be increased by high triglycerides, but also high triglycerides are usually a signature of prediabetes, diabetes, a diet rich in fast foods, sugared beverages, often when people are overweight and hypertensive. So in some ways, it's almost hard to tease out high triglycerides as a solo risk factor because they're associated with so many other risk factors. And it's that combination, that milieu I talked about, remember metabolic syndrome, that triglycerides are associated with that can cause coronary artery disease. And there was a question, how does one reduce triglycerides? So since that's a fat that comes from sugars and starches, a lower carbohydrate diet can definitely help with that and moving more.
Thank you for that great response, Dr. McNeil. There was a question that said, what if you can't tolerate statins? And I think this is a really great question because statin intolerance is certainly a very real phenomenon that can affect people. I always tell my patients that we want to optimize your heart health, but we never want to make you miserable with the treatment. There are a number of non-statin medications that are out there that can lower your cholesterol and reduce your risk of heart disease. And a number of these have actually come out in recent years and have become much more readily available. So I would definitely ask about non-statin therapies to lower your cholesterol. Dr. McNeil, did you have anything else to add to that?
Yeah, I could give a talk as you could, Dr. Kulkarni, on statin intolerance. And what I point out is that we start children anytime in Europe after the age of 6, in the U.S. after the age of 8, 9, or 10 that have genetically high cholesterol on statins. and they tolerate them just fine because they don't have our other usual aches and pains that we acquire as adults. And one of the things the pain medicine doctors talk about is metastatic or rebound pain. So your brain goes on high alert if you have pain anywhere. So any little symptom we have gets amplified. Say if we have chronic back pain or knee pain or hip pain, it all gets amplified. And so in many cases, what the studies show is that if people don't know they're taking a statin, there's really hardly any increase in the reported side effects of statins compared to the placebo. But of course, there's been barrage on the internet about the dangers of statins. And really, I just can't emphasize enough how important these drugs are to reducing the risk of heart disease, how inexpensive they are compared to the new drugs, and how safe they are. And I use as evidence the fact that we start children on these drugs and continue for a child's lifetime to decrease the risk of cardiovascular disease. So remember, all that statins do is help the liver function the way it's supposed to by taking the cholesterol back up out of circulation. So no, they don't have any toxic side effects except in extraordinarily rare cases.
Thanks for that great response. We're seeing all of these lovely questions come in through the chat box, and I'm so sorry that we're not going to be able to answer every single one of them. I'm going to take one more question. But before I forget, I do want to make sure that everyone knows that we're going to put together a recording of this webinar later this week and send it out to you. So hopefully that will help address some of the questions that you wanted to go back to through our talks. The final question that we're going to take is, how can you lower your LDL cholesterol, which is a great question. I tell my patients in general, your LDL cholesterol really is a combination of kind of what you inherit genetically in terms of how much cholesterol your liver makes and what you eat. From a lifestyle standpoint, you can lower your LDL cholesterol by cutting back on saturated fats. Saturated fats, the bigger offenders in terms of saturated fats are things like red meat, high-fat dairy, so whole milk, heavy cream, butter, ice cream, all of the things that are delicious in life. I say that jokingly: cookies, cakes, pastries, donuts. Every egg yolk, like we talked about, has 200 to 300 milligrams of cholesterol in it, as well as fats. So any animal-based fats or tropical fats that are solid at room temperature, things like coconut oil or palm oil. All of those foods are really high in saturated fat and will raise your LDL cholesterol. So if you have high LDL cholesterol, these are the foods that I would think about cutting back on. Exercise is also very important. There are two metrics that I encourage everyone to try to hit when it comes to exercise. One is that the American Heart Association recommends that you walk about 10,000 steps a day, which is approximately 5 miles. And the idea is just to get you to move more. That doesn't have to be all at one time. And then we want you to get 150 minutes a week of what we call moderate intensity activity, which is, anything that gets your heart rate up where you feel like you're pushing yourself a little bit. 150 minutes a week breaks down to, if you exercise 30 minutes a day, 5 days a week, it'll get you there. And then the combination of kind of the diet that we talked about and exercising can really help optimize your LDL cholesterol naturally. And as Dr. McNeil discussed, sometimes, we need to do more than just, diet and exercise, and we need to use medications for this, such as statins. Anything else that you want to add to that, Dr. McNeil?
No, I completely agree with everything he said. We always talk about poly and monounsaturated fats as being good fats. And so, if it's a footless fat, if the less feet a fat has is good. So 4-footed, 2-footed. I don't know any 1-footed, no-footed, vegetable, not vegetables, but things like nuts. All of those good fats that have no feet are really good to increase the heavenly cholesterol, and actually even avocados even lower the bad cholesterol a bit.
Yeah, thank you for that. Well, with that, it is 1 p.m. and we are going to wrap up. I know there were a lot of questions in the chat box that we weren't able to get to today, but we are really grateful that you took the time out of your day to attend our webinar. Please reach out if you have any questions. If you have any clinical questions, we're always happy to assist in your care as well. All right, thank you.